Hi, this video is going to be about abdominal tuberculosis. So we'll be taking a look at the causative agent, what are the sources of infection, the pathophysiology types, the presentation, and complications in this video. So first, let us understand what the term abdominal tuberculosis comprises. So let's imagine that this is the gastrointestinal tract. The gastrointestinal tract inside the abdomen, and this is the peritoneal covering, with this being the pathophysiology. Okay, so the term abdominal tuberculosis refers to tuberculous infection of the gastrointestinal tract, the mesenteric lymph nodes, the peritoneum, the omentum, and the solid organs, which comprises of the liver, the pancreas, and the spleen. So tuberculous infection of any of the above will be considered abdominal tuberculosis. So next, moving on to the causative agents. In a majority of the cases, it is Mycobacterium tuberculosis, that is in approximately 90% of the cases, with Mycobacterium bovis causing the rest, which has largely been eliminated. So Mycobacterium tuberculosis is gram-positive, aerobic, non-motile, and non-spore-bearing organism, which leads to abdominal tuberculosis. Next, let us take a look at the risk factors for abdominal tuberculosis. Any state of immunosuppression, malnourished individuals, in cases of overcrowding, poor socio-economic conditions, these entail the risk factors for abdominal tuberculosis. So now let us take a look at the roots of abdominal tuberculosis. So first, via ingestion, which can be via ingestion of contaminated food, or via ingestion of sputum. Next, we have spread via hematogenous route, can be lymphatic spread, spread via adjacent organs, and dissemination in bile, particularly if the liver is affected. So the primary, it is further divided into primary and secondary causes of abdominal tuberculosis. Primary cause is mainly due to Mycobacterium bovis. So ingestion of contaminated foods is usually under the primary cause, which is usually caused by Mycobacterium bovis. All the rest are mainly due to Mycobacterium tuberculosis. And it would be very interesting to note that approximately 15 to 25% of cases with pulmonary tuberculosis have concomitant abdominal tuberculosis. Next, let us take a look at the pathogenesis. Okay. So, if these are the Mycobacterium tuberculosis, once they enter the gastrointestinal tract, they infect the mucosal layer, following which they enter into the lymphatic tissue, invade the lymphoid tissue in the submucosa, leading to the formation of granulomas, activated macrophages, and after 2 to 4 weeks, these granulomas undergo caseous necrosis, which can lead to spread deeper or can lead to formation of ulcer. That is how the tubercles spread to the serosal layer and lead to formation of ulcers. Next, we'll be taking a look at the types of abdominal tuberculosis. So first, we have mentioned the gastrointestinal tract. We'll look at it a little further. So the gastrointestinal tuberculosis would be further divided into tuberculosis of ileocecal region, of the ileal region, esophageal, gastroduodenal, and the anorectosigmoid. So the tuberculosis of the ileocecal region will be further divided into ulcerative, hyperplastic, or ulcero-hyperplastic. So the ulcerative type accounts for approximately 60%, with the hyperplastic type accounting for 10% and the rest being ulcero-hyperplastic. So now we'll be taking a look at the differences between the ulcerative and the hyperplastic type. So the ulcerative type is usually secondary to pulmonary tuberculosis, where this is usually primary tuberculosis. Again, that's not a rule, but this is something that has been observed. In this case, the virulence of the organism is much higher, whereas in the other, the virulence is less. The body resistance in cases of ulcerative is low, whereas in a case of hyperplastic, the patient has good body resistance. It usually leads to formation of ulcers, which when heal leads to formation of strictures. On the contrary, this hyperplastic usually presents as a mass in the right iliac fossa, and due to this stricture as well as mass, both of these patients can present with subacute intestinal obstruction. Next, moving on to the ileal tuberculosis. Ileal tuberculosis is usually of stricturing type. We see multiple strictures in the terminal ileum, and the patient usually presents with intestinal obstruction. Uh, Patients may also present with perforation, but it is rare. So next, moving on to the esophageal tuberculosis. The differential diagnosis is an esophageal carcinoma. It usually presents in mid-esophagus, and the patients usually present with ulcer, dysphagia, or dinophagia, or a low-grade fever. Next, coming on to the gastroduodenal tuberculosis, the differential diagnosis of this is a peptic ulcer disease and can present with gastric outlet obstruction. The anorectosigmoid tuberculosis usually presents with anal fissures, non-healing, multiple fistulas, and again, the differential diagnosis is a malignancy. So, amongst all the above gastrointestinal tract tuberculosis, the most common is the ileocecal region, and the least common is the gastric region. And there are multiple reasons for this. So, ileocecal region tuberculosis is the most common amongst the gastrointestinal tuberculosis within the abdominal tuberculosis due to one, stasis of intestinal content in this region, due to the presence of abundant Peyer's patches, due to the presence of alkaline medium, due to decreased digestive activity in this region, and due to maximum absorptive area. So next, moving on to the peritoneal tuberculosis. So the peritoneal tuberculosis are acute, chronic, which is further divided into ascitic, encysted, plastic, and purulent. So the acute type mimics acute abdomen. So it's a non-table diagnosis. Usually the patient will present with features of peritonitis, and it is due to either rupture of mesenteric lymph nodes or can be due to perforation. Next, moving on to the chronic type, the ascitic type usually presents with distended abdomen, and patients with patent processus vaginalis may also have hydrocele. So when an ascitic tap is done, we find a straw-colored fluid from which this acid-fast bacilli can be isolated. This fluid, the ascitic fluid, is rich in lymphocytes and has a high specific gravity. When this ascites gets loculated, it leads to encysted ascites. This occurs because of fibrinous deposition. In this, we do find dullness, but it is not a shifting dullness. And so the patients may present with an intra-abdominal mass, which the differential diagnosis could be an ovarian cyst, could be mesenteric cyst, or the retroperitoneal cyst. So next, moving on to the plastic type, this occurs due to widespread adhesions. So the patient in this case presents with multiple episodes of colicky abdominal pain, has diarrhea, has weight loss, and the feel of the abdomen may be doughy. The differential diagnosis in this case is peritoneal carcinomatosis. Next, moving on to the purulent type. More often than not, this is due to TB salpingitis. So in this case, the patient may present with a mass in the lower abdomen, which is filled with pus, and the patients may also present with an umbilical fistula. This umbilical fistula is mainly due to this cold abscess which gets adherent to the abdominal wall and forms the fistula. Patients in this case usually have genitourinary tuberculosis. Next, moving on to the mesenteric lymph nodes. So the infection in this case is usually due to Peyer's patches, and more commonly the right-sided lymph nodes are involved. They can present with symptoms such as pain, which may be localized to the right iliac fossa. They can present with a mass in right iliac fossa, and sometimes when the coils of the bowel gets adhered to these lymph nodes, the patients can also present with intestinal obstruction. The differential diagnosis in cases of large mesenteric lymph nodes can be retroperitoneal tumor or lymphomas. Next, moving on to the tuberculosis of the omentum. So in this case, patients usually have rolled up omentum with thickening. And finally, patients can present with tuberculosis of the solid organs with very non-specific clinical features. So we have covered abdominal tuberculosis, the types, the causative organism, the mode of spread, the clinical features. In the next video, we'll be looking at the diagnosis and the management. So let's take a look at the revision. Mycobacterium tuberculosis is the causative agent in 90% of the cases, which is gram-positive, aerobic, non-motile, and non-spore-bearing, with Mycobacterium bovis causing a minority of abdominal tuberculosis, the risk factors being immunosuppression, malnourishment, overcrowding, and poor socioeconomic condition. The roots of abdominal tuberculosis are via ingestion of contaminated food, leading to the primary tuberculosis, which is caused by M. bovis, and ingestion of sputum, hematogenous root, lymphatic spread, adjacent organs, and dissemination in bile is usually due to Mycobacterium tuberculosis. We've discussed the pathogenesis, where we see the organisms gain entry into the mucosa, spread into the submucosa within the lymph nodes, leading to the formation of granulomas. And after 2 to 4 weeks, when caseous necrosis occurs, the spread occurs either deeper or superficial up till the serosa, or leading to the formation of ulcers. Next, looking at the various types, we've seen in the gastrointestinal tract that ileocecal region is the most common, and we've discussed the various causes for that. Within the ileocecal region, we've seen that there are 3 types: ulcerative, hyperplastic, and ulcerohyperplastic, with ulcerative type being the most common. And this is secondary to pulmonary tuberculosis, where the virulence of the organism is higher and the body resistance is lower. Usually patients have ulcers, which leads to stricture formation and present with obstruction. Ileal tuberculosis usually present with strictures. The esophageal tuberculosis presents in mid-esophagus with dysphagia and odynophagia, and the differential diagnosis is esophageal malignancy. The gastroduodenal, which is the least common differential diagnosis, is peptic ulcer disease, and patients can present with gastric outlet obstruction. Another type is the anorectosigmoid, where patients present with anal fissures, fistula, and the differential diagnosis is your malignancy. Moving on to the peritoneum, we have acute and chronic. The acute mimics acute abdomen, could be due to the rupture of the mesenteric lymph nodes or due to perforation. The chronic type is ascitic, encystic, plastic, and purulent, with ascitic type having distended abdomen, and patients with a patent processus vaginalis can present with hydrocele. The encysted type occurs when there is loculations within this ascitic type, leading to mass formation, and the differential diagnosis could be an ovarian cyst, mesenteric cyst, and a retroperitoneal cyst, with the plastic type having widespread adhesions and leading to recurrent obstruction, the differential diagnosis being a peritoneal carcinomatosis. The purulent type, usually due to genitourinary tuberculosis and TB salpingitis, can present with a mass abdomen as well as umbilical fistula. The omental tuberculosis usually present with rolled up omentum with thickening. Patients usually do not have any features, and it is an intra-op diagnosis. The mesenteric lymph nodes are usually due to Peyer's patches, and right-sided lymphadenopathy is more common. So patients can present with pain in the right iliac fossa, a mass in the right iliac fossa, and with obstruction in case the bowel loops get adherent to the abdominal lymph nodes. The findings, the clinical features of solid organ tuberculosis are rather non-specific, and hence the diagnosis is very difficult. In the next video, we'll be looking at the diagnosis and the management. Thank you so much for watching. If you found the topic a little easier, please do hit the like button, share, and subscribe. Thank you.